Hello, everyone. Welcome to today's webinar titled Cannabis Use Disorder, Insights from Professor Nick Lintzeris. My name is Jake Dizard, and I'm the Senior Research Officer here at Penington Institute. We are a not-for-profit organization focused on supporting cost-effective approaches that maximize community health and safety in relation to drugs, including pharmaceuticals and alcohol. Today, I am speaking from the never-ceded lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past and present. I would also like to acknowledge the traditional owners of the multiple lands that people are joining us from today. Thank you all so much for joining us this morning. As essentially everyone here today is pretty keenly aware, over the past few years, Australia's medicinal cannabis regime has been the topic of immense interest and no small measure of controversy. Here at Penington Institute, we aim to support informed discussion on a broad range of cannabis-related issues in Australia, very much including medicinal cannabis. In 2022, we developed the Cannabis in Australia 2022 report that truly comprehensively documents current approaches to different forms of cannabis in all the states and territories. And regarding medicinal cannabis specifically, it discusses regulatory scheme and associated strengths and limitations, professional and public perceptions of medicinal cannabis, and ongoing barriers to medicinal cannabis access. We also updated that late last year with Cannabis in Australia 2023, which includes a wealth of data on the medicinal cannabis program throughout Australia. And so I commend you to visit our website and check out those reports. Today, we have an illustrious speaker with us to discuss a facet of medicinal cannabis that may sometimes be overlooked a bit, the prescribing of medicinal cannabis as a treatment approach for cannabis use disorder, akin to other agonist or substitution treatments, such as methadone for opioid use disorder or nicotine replacement for cigarettes. Professor Nick Lintzeris from the University of Sydney is the perfect guide to this mildly provocative topic. As most people present today will probably know, Nick has been one of Australia's and really the world's leading addiction medicine specialists and clinical researchers for many years. Indeed, he has almost 3 decades of experience working in the alcohol and other drug sector in Melbourne, London, and Sydney. Nick's research interest areas have included evaluation of new treatment interventions and medications and translational research approaches. He is Director of Drug and Alcohol Services at the Southeast Sydney Local Health District and Professor in Addiction Medicine at U Sydney. He also sits on the Board of Directors of Penington Institute. He has worked on clinical research and treatment regarding a broad range of drugs in addition to cannabis, including opioids, psychostimulants, and benzodiazepines. And this diverse background makes Nick the perfect person to discuss cannabis and cannabis use disorder within the context of overall drug treatment, harm minimization, and drug policy. A few notes before we get started here. First, today's webinar will run for 1 hour and mostly consist of Nick's presentation, followed by some time for audience Q&A. We should have 15-20 minutes at the end of the program. I encourage you to use the Q&A function in Zoom here to ask questions throughout today's discussion, and we will try to answer as many as we can. Also, a reminder that this session will be recorded and accessible on our website, www.pennington.org.au. With that, I will turn it over to Nick, who will get us started. And Nick, the floor is yours, including any additional words about yourself or your cannabis work you'd like to provide. Thanks so much for being with us.
Thank you, Jake. Thank you, Reese, and thank you to the Penington Institute for extending this invitation, and welcome everybody. I'm just going to start sharing my screen. Goes well. And if you can just confirm, Jake, that you can actually see the cover slide there. Great, excellent. Okay, so welcome everyone. And this morning we're going to be talking about medical cannabis and cannabis use disorder in Australia. And you can see my affiliations there. Just acknowledgements and disclosures. I have received research funding for unrelated research, mainly in the opioid treatment area. I've also received research funding over the years from New South Wales Government and NHMRC for medical cannabis research. I'm also on the board of the Penington Institute and the Australian Medicinal Cannabis Association. And in terms of acknowledgements, also just want to acknowledge the traditional lands in which I'm speaking on. I'm in Gadigal country, and extend acknowledgements to elders past, present, and emerging. Okay, so what are we going to be talking about today? So I was going to just provide a brief overview around what we mean by cannabis use disorder and its treatment, a brief overview of medical cannabis in Australia, and there's some new data which has just come out, and so I'll be giving us a sense of just what does the face of medicinal cannabis look like in Australia. Then focus on really the main sort of area for today is this issue of can we and should we be using medicinal cannabis to assist people with cannabis use disorder? And it'll be a range of kind of approaches there they'll consider. Plus, I also want to touch upon this issue, which is an important issue, which is how do we address cannabis use disorder in patients being treated with medicinal cannabis for other conditions? And I think this is a very important issue for us. We have a long history of getting it wrong when we think about our approach to the use of prescription opioids, prescription benzodiazepines, a range of mental health medications, where over the years, I think it's fair to say that when these medications first came out, we did not pay adequate attention to some of the concerns around the development of things like opioid dependence in chronic pain patients. And I think it's important that we're aware of some of the risks there, and that we can also then tailor treatment responses accordingly. So that'll be an overview of the presentation, and let's get going. So cannabis use disorder. So most recently, we've just had the National Household Drug Survey data released. The data is for the year 2022. And what we can see in terms of the patterns of profile of use, there has been an increase in lifetime use of cannabis since the last survey in 2019. However, when you actually look at the last year cannabis use, that's remained pretty stable at about 12% of the population reported using cannabis at least once in the last 12 months. Now, there's actually a bit of an age breakdown there, and you can see on the right that whilst we often have a tendency to blame youth of today for all the harms that happen, actually what we're seeing is that to a large degree, the growth in cannabis use over the last sort of 5-10 years, it's less an issue of increasing use amongst young people, but it's actually more about older Australians are not reducing their cannabis use. So this is something that we've seen with a range of other drugs over the years, opioids, alcohol, benzodiazepines, that we're not seeing, you want to call that sort of the baby boomers and the Gen Xers are not reducing their drug use in the way prior generations had done so. So they seem to be continuing their level of use. So it may well be that the increasing overall sort of prevalence of use is being driven more by older Australians who continue to use cannabis. It's possible to estimate that around 2.5 million Australians use cannabis in a 12-month period. That brings us on to the issue of cannabis use disorder. So what do we mean by cannabis use disorder? So this is a term that comes out of DSM-5. Other classification systems such as ICD have used other language such as abuse and dependence, but there's a lot of overlap. Throughout the presentation, I'll be using cannabis use disorder. The criteria for a cannabis use disorder there on the right, and essentially what a cannabis use disorder means, that individuals continue regular cannabis use despite there being clinically significant impairment to that individual. DSM recognises this as a continuum rather than as a sort of binary on-off. And you can see there the number of criteria required. So moderate or severe cannabis use disorder, you need to have at least 4 criteria in the last 12 months. And moderate to severe maps closely with previous terminology of dependence. So throughout this, I'll be focusing a lot on moderate and severe cannabis use disorder because that's the sort of the old language of dependence that many of us will be familiar with. You can see the criteria there on the right, and a lot of them have to do with this issue of continuing to use cannabis despite there being persistent harms. Also issues around cravings, continuing to use despite sort of using for longer than you'd hoped for, and unsuccessful attempts at coming back. Also want to highlight the last two criteria there, sort of physiological criteria of tolerance and withdrawal. Now, there's a lot of conjecture around whether or not these should or should not be used when they're sort of included in criteria for prescription drugs. So with opioid use disorder, where an individual patient uses the drugs as prescribed, then those last two criteria are not actually factored into the diagnosis of an opiate use disorder. So if a patient is basically taking their opiate medication entirely as prescribed by their doctor, then tolerance and withdrawal are not factored in. Throughout the presentations I'm going to be giving, we're not in a position to actually separate out a lot of this issue of whether or not we should include tolerance or withdrawal, because a lot of it has to do with the issue of whether or not patients are taking it as prescribed. There's a lot of there's a range of issues there to consider. But for the time being, I will be using data that includes all 11 criteria, but recognizing that if you remove tolerance and withdrawal, then the rates of cannabis use disorder drop significantly amongst medical cannabis users. So amongst people that use cannabis, we can estimate about 10% of people who used in the last year meet criteria for dependence or severe use disorder. That rate increases when we start looking at people that use cannabis on a more regular basis. So amongst people that are using cannabis daily or almost daily, then the rates are closer to 30 to 50% of people meet criteria. I'll be looking at rates amongst medicinal cannabis patients later, but suffice to say that in research we've done here in Australia, that we're seeing very comparable rates of cannabis use disorder amongst medical cannabis patients as we do with non-medical users. It is possible to estimate that we have around 250 to 500,000 Australians meet the criteria for a cannabis use disorder, and probably about 1/3 of those are meeting criteria for dependence. Another dimension to be aware of is cannabis withdrawal. Now, cannabis withdrawal is the emergence of a cluster of symptoms that happen when you stop or markedly reduce your cannabis use. The symptoms are most severe in the first week. However, symptoms can persist for a few weeks. The prevalence of cannabis withdrawal is about 1/3 of people that use cannabis less than daily will develop it, but it's as high as about 50% amongst people using on a daily basis. And estimates here in Australia is about 1/3 of medical cannabis users experience a withdrawal syndrome when they've attempted to stop. You can see the range of symptoms there on the right. This is data from medicinal cannabis users. This is from the CAMS 2020 survey that we've been rolling out in Australia every 2 years. And you can see that by far the most common symptoms are sleep, anxiety, restlessness. And that's important because I'll be returning to that issue later. What's the impact of cannabis use disorder on individuals and society? Well, I think we're all familiar with some of the potential harms that can happen for individual consumers, and most commonly it's mental health harms, physical health harms, and a range of social harms, which include financial problems, legal problems, employment, relationships. And we have the issue of motor vehicle accidents in Australia as well. The overall cost of cannabis use in Australia was estimated, this is using data which is now almost a decade old, but it was estimated at over $4.5 billion a year, of which over half of that goes to crime-related costs, and a much smaller proportion goes into treatment. Talking about treatment, our most recent data is from 21-22. For this, the alcohol and other drug treatment episodes put out by the AIHW, and cannabis was the primary drug of concern in 19% of all people presenting for drug treatment, and is listed as a drug of concern in 30%. So almost a third of all people presenting for drug and alcohol treatment in Australia identified cannabis as being a problem drug for them. And this is also looking at sort of other harm-related data. You can see there cannabinoid-related hospitalisations have remained fairly stable over the last decade or so. We were concerned that there was a peak there in 2021 and whether or not that was starting to reflect the increase in medicinal cannabis use or other issues going on, but you can see that that number has dropped in the most recent sort of data. When we look at cannabinoid-related deaths, you can see there was the spike there in 2017, 2018, which has sort of returned back to earlier levels. Most of us think that that may well have been related to some of the synthetic cannabinoids that were being used about 5-10 years ago. These are the spice products that were quite prevalent in parts of Australia about a decade ago. Those numbers have reduced dramatically back to sort of what has been sort of considered more baseline levels. So how do we provide treatment for people with cannabis use disorder that are seeking assistance? Our conventional treatments are psychological therapies and cognitive behavioural therapy or motivational enhancement treatment tends to be the mainstay of treatment, and the majority of Australians seeking treatment for cannabis use disorder received a counselling intervention. Now, these counselling interventions tend to be more effective in those individuals with less severe cannabis use disorder and who also have got more sort of recovery capital or greater sort of resources behind them. So less effective in the more marginalised and disadvantaged populations. We can also help patients with withdrawal management. Our main issue there is supportive counselling. In the same way, we provide supportive counselling for other types of withdrawal. Plus, our medication options are limited. We generally use symptomatic medications with some sedatives such as benzodiazepines for a short period of time. There's also self-help approaches, increasingly groups such as Smart Recovery and Marijuana Anonymous. It's fair to say that our outcomes are not great. It's estimated that with these treatment approaches of counselling, withdrawal, self-help, that the majority of people, probably about 3/4, resume heavy cannabis use within 1 to 6 months of completing treatment. So that's probably not dissimilar to what we see with some other drugs of concern, probably not that dissimilar to what we're seeing with alcohol and psychostimulants as well. We tend to have much better outcomes with opioid treatment, and that's because we have more effective opioid dependence treatments in things such as methadone, buprenorphine maintenance, which raises the issue there, of is there a role for medicinal cannabis in the treatment of cannabis use disorder? And a lot of this comes from an increasing recognition that when we're treating any form of substance use disorder, all the evidence tells us that when we combine counselling and medications, and it could be argued peer support, that we tend to have better outcomes than when we only provide medication or counselling. So the search is out there to find effective medications that we can combine with counselling approaches. Now, to date, systematic reviews of treatments of medications for cannabis use disorder, we've not been able to find any effective medications using sort of a lot of the conventional medications that have been researched, such as antidepressants, antipsychotics, N-acetylcysteine, and other medications like that. So to date, we haven't had much success there in finding efficacious medications. And this has obviously brought a lot of people to start thinking about, is there a role for medicinal cannabis for treating cannabis use disorder? Okay, I'll come back to that issue in a moment, but let's do a quick overview of what we mean by medicinal cannabis in Australia and look at some of the recent data. So we've recently had the National Household Drug Survey just released, and this included medicinal cannabis. They included in the 2019 survey, but there were so few people using medicinal cannabis, prescribed cannabis, that the numbers were really low and it's difficult to interpret their data. We've got much better data now for 2022, 2023, and they've been able to come up with the following estimates. So the pie chart on the left has estimated that amongst Australians aged 14 and over, 19 million Australians did not use cannabis, but over 2.6 million Australians did use cannabis in the past 12 months. And you can see the breakdown there that the blue there should be, medical cannabis. Estimated that around 700,000 Australians used medical cannabis in 2022, and just under 2 million had used cannabis for non-medical reasons. And you can see there in the graph on the right there that of the 12% of people that reported using cannabis in the last 12 months, about 1% said, I use it only for medical reasons. 2% said, I use it for both medical and non-medical. And about 9% said that they used it for non-medical reasons only. The survey also asked Australians, where do they source their cannabis? Now, when we throw all people together, you can see 92% are still reliant exclusively on an illicit market. So these are not prescribed by doctors. And of all Australians who use cannabis in the last 12 months, about 7.5% said that they had accessed it from a doctor under prescription. About 5% of those was always prescribed by a doctor. When we look at those Australians who said that they use cannabis for medical reasons, it's still only about 30% had accessed that from a doctor, and 70% were continuing to access medical cannabis through illicit sources. Now, there's a lot of reasons why Australians aren't, why are 70% of Australians using cannabis for medical reasons not going to their doctor to get a prescription? Our data from CAMS surveys suggest that cost, stigma, confidentiality, and difficulty finding doctors were the three main reasons why patients continue to rely on illicit supplies. Now, what's really interesting is when we look on the right hand there, the frequency of cannabis use. And this is really interesting because when we look at people that had used cannabis for non-medical reasons only, the vast majority could be described as occasional users of cannabis. So 30-odd% had only used once or twice, 20% only used every few months, and 11% used only about once a month. So when you're looking at how many people were reporting using at least once a week, it's only about 30%. Now, when we contrast that to people being prescribed or using, medical cannabis, it's much higher. We're talking much higher rates of daily use or almost daily use. So that's quite important in understanding some of the implications of medical cannabis use. It tends to be far more regular in its pattern of use, and that's probably understandable given that many patients use it for chronic conditions which are affect patients on a daily basis. What is being prescribed? So, TGA approvals for medicinal cannabis. Now, this is very, very difficult for us to extrapolate. Approvals does not mean number of patients. That's really important to understand. So, for example, if I was prescribing to a patient and I had to prescribe, or I was prescribing a THC dominant product and a CBD dominant product, so two different products, I would need 2 permits or 2 approvals. So that would look as 2 cases, not 1 patient. So 2 approvals, not 1 patient. And our approval system, the TGA categorizes it into 5 categories, where you go from THC dominant, which means more than 98% THC, all the way down to CBD dominant, category 1, which is more than 98%, and there's a mixture there in the middle. So you can see that it's fair to say that THC dominant dominates the market by far, both amongst the authorised prescriber and amongst the special access schemes. Those two, authorised prescriber and special access scheme, are just the different systems by which doctors can get TGA approval. Probably not worth spending much time more talking about the different systems. But you can see we have a THC dominant marketplace. On the right hand, you can see the types of drugs that are being prescribed in terms of formulations. By far, the majority is oral liquid or capsules amongst the authorised prescriber. Dried herb, so that's herb, so it looks like cannabis plant, prescribed for vaporizing, not for smoking, is more common amongst the special access scheme. But we still have a predominant oral market with increasing amounts of THC, of herb being prescribed. And you can see there's a tail off in terms of other formulations. In terms of the conditions being treated, this comes from our CAMS data. The TGA data doesn't allow us to interrogate this effectively for the authorised prescriber. So I've used the CAMS data. You can see there the vast majority is for pain, and the numbers are increasing for pain. Mental health categories are the second most common, and amongst that, anxiety, PTSD, and depression are the three categories. We're also seeing it being used for sleep, neurological conditions. Okay. So let's look at the issue then of overlapping those two subjects of cannabis use disorder and medical cannabis. So I'm going to focus on, first and foremost, the issue of using cannabis for managing withdrawal, then look at how we can use it for people that want to treat their cannabis use disorder, and then look at the issue of medical cannabis as harm reduction for people with cannabis use disorder. So I'm not going to go through these slides, just putting them up there, and I'm happy for the slides to be circulated later so you can look at these in your own due leisure. There's been 3 RCTs looking at synthetic THC products, all done in the US. They generally basically suggest a reduction in heavy cannabis use, but we don't achieve great abstinence rates. The other 3 studies have been trials using nabiximols. Now, nabiximols is also known as Sativex in this country. So nabiximols is an oral mucosal spray. It is plant extracted THC and CBD, and each spray has about 2.5 milligrams of THC and CBD. It's licensed in Australia for multiple sclerosis, and usually the dose there is 8 to 12 sprays a day, which is around 20 to 30 milligrams a day of nabiximols or THC. So they're the 3 studies that have looked at using nabiximols for treating cannabis use disorder, and I'll go into these a little bit more detail. So the first study we did, this is a study done in Sydney and Newcastle, and Dave Alsop was the lead investigator. Dave was very instrumental in a lot of the early medicinal cannabis work done in Australia. Unfortunately, he passed away 8 years ago now. So this study was a randomized controlled trial comparing placebo to Sativex in about 50-odd patients. It was done in an inpatient setting, and the main outcome was looking at cannabis withdrawal severity. We were using quite high doses of nabiximol. So this was up to 32 sprays a day, which is around 80 milligrams of THC and 80 milligrams of CBD. Because it's the spray, and the bioavailability is a little bit different. This is probably closer to around 100 milligrams of oral THC a day. It was spread out over 4 sprays during the day. You can see there's a significant reduction in cannabis withdrawal severity. Also, more patients completed the withdrawal episode on the Sativex arm than the placebo arm. So when you see less severe withdrawal and higher completion rates, they're fantastic cannabis withdrawal treatment outcomes. However, when we went and followed people up a month after leaving detox, what we found is that the majority, 70%, had relapsed to cannabis use. And there was no difference between the placebo and the Sativex arms. So what this was a really good reminder of, that in the addiction medicine space, we need to be quite cautious about what we can achieve with any withdrawal treatment. Withdrawal treatment itself, withdrawal-only treatment, rarely results in long-term changes in substance use. So it really highlights the idea of the limitations of withdrawal-only treatment. Nevertheless, withdrawal can be a real barrier for a lot of patients in reducing their cannabis use. So if you can't get past the first week without using cannabis, then it's very difficult to achieve 4 weeks or 12 weeks if you can't even get through that withdrawal period. So cannabis withdrawal treatment can be important, but on its own, it's not enough. So what's my take about the use of medical cannabis for managing cannabis withdrawal? The first thing I really want to sort of emphasize is the need for a stepped care approach. Many regular cannabis users stop cannabis use with minimal withdrawal discomfort and never need to go and seek treatment. So if you're one of those regular cannabis users who can just stop, then great. You don't need to bother treatment providers or waste your time going and getting treatment. However, a considerable portion of people can't stop cannabis on their own. And for those individuals, I would recommend going and getting standard withdrawal treatment. Now, tends to be a lot of supportive care. So getting organised, coping with symptoms, cravings, sleep, the role of exercise. So a lot of this is just standard supportive withdrawal care. And the standard symptomatic medication that we use for cannabis withdrawal tends to be benzodiazepines targeting the sleep and the anxiety. We don't like using it long term, usually only maybe up to a week's supply because of the concerns of these people then sort of running into problems with benzos longer term. So my advice would be that if you can stop your cannabis using standard withdrawal treatment, then do so. But if you're one of those individuals for whom standard care is not effective, then that's when I would suggest think about the role of medicinal cannabis. And how would we deliver that treatment? Well, generally would recommend a short-term treatment program, say 7 to 14 days, which is consistent with the period of maximal withdrawal severity. And the idea is that we use tapering doses over that 17 to 14-day period. I would strongly suggest using oral THC, usually in the range of that 40 to 60 milligrams a day to begin with, and then reducing by 5 to 10 milligrams a day. Can you do this with vaporized THC? Yes, but I think oral doses for withdrawal are much better. It breaks that behavioral association of reaching for a bong or for a joint. So that's sort of an important sort of nexus to break during withdrawal management. Plus the other nice thing about oral medications is that they're much longer acting and so much better for withdrawal management than having to use a drug which wears off after 90 minutes or 2 hours, then you've got to dose yourself again, which just keeps you in that sort of, drug using behavior. So I would strongly recommend using oral for that. Now, what happens if you start to reduce the dose and patients start relapsing or they're unable to cope with their reduced doses? That's when I would suggest considering a more prolonged reduction and maybe turning that into a long-term form of treatment. With all withdrawal treatment, really important to encourage ongoing treatment. Otherwise, most people relapse. Okay, so that's withdrawal management. How about the issue of cannabis use disorder treatment? So this is really about longer term treatment rather than just getting through that initial 1 or 2 weeks of detox. So a number of studies have been done, but by far the largest and most important study is a study that I led a few years ago and was published in JAMA. And this was a pretty straightforward randomized controlled trial. It was double-blinded and it was Sativex versus placebo, 12 weeks of treatment. Alongside case management and cognitive behavior therapy. We used decent doses of around 50 milligrams of THC in the forms of nabiximols, which is equivalent to 60 to 80 milligrams of oral. You can see the doses that we were using there. What did we find? Key findings. So we found significantly less illicit cannabis use amongst patients on the nabiximol arms, that's the top left. On the top right, you see the differences in the profile there. And what we basically found is that the majority of patients randomized to nabiximols either stopped or dramatically reduced their illicit cannabis use, whereas the majority of people on the placebo arm continued to use cannabis 6 or 7 days out of 7 over the 12-week period. But what was really interesting is that when we followed people 12 weeks after stopping the medication, so they got 12 weeks of medication and counselling, then we left them alone for 12 weeks and we came back and revisited and we asked them tell us about your cannabis use. And what we found was a significant reduction in people that had returned to cannabis use amongst the nabiximols arms. And so we asked about abstinence in the 4 weeks of that 24-week, and almost half of the nabiximol group reported no illicit cannabis, no cannabis use in that sort of 3 months after treatment. And that was only around 20% of the placebo arm. So this to us tells us this looks like potentially a bit of an NRT model, nicotine replacement therapy model, where we'll often use NRT, say, for 8 or 12 weeks and then stop it, rather than what I've called a methadone maintenance model, which is ongoing continuous treatment. Just some other things to be aware of. Very well tolerated. So these really high doses were well tolerated by cannabis-dependent individuals, and there was no concerns around cognitive performance in patients receiving nabiximols. These people, there was absolutely no difference to the arm receiving placebo medications in terms of the cognitive performance, which tells us it should be safe in terms of those activities that require sort of cognitive function. So, what role of medicinal cannabis for treating cannabis use disorder? So our RCTs suggest that we see improvements in unsanctioned or illicit cannabis use during and following the medication period. But I also really want to emphasize, this was not just a prescription. This was a combination of a prescription and talking therapies. And I really want to emphasize that whenever we are thinking about the treatment of any substance use disorder, you're generally going to see better outcomes when you combine the two. And that's actually what we found in our randomized trial, that when we actually looked at those participants who attended more counselling sessions, they actually had better outcomes in terms of their cannabis use and other psychosocial functioning. Our data tells us that high-dose THC in that range of 50 to 80 milligrams a day oral is safe. And I want to contrast that because when we're using THC for non-dependent cannabis individuals, so if we were using it in someone, relatively cannabis naive or a history of using it, 20 years ago, and if they're turning up to get treatment for chronic pain, for example, or for their sleep disorder or their anxiety, then usually the doses that get recommended are in that 10 to 30 milligrams oral THC a day. We're using much higher doses when we're treating patients with cannabis use disorder. And if you think about it, that makes perfect sense because of the issue of tolerance. These people are tolerant to the effects of cannabis and they need much higher doses. So I would suggest a very similar approach of a stepped care approach, that if you can stop your cannabis without treatment, great. If you can't stop without treatment, then look at whether or not counselling and or withdrawal treatment can assist you reaching your goals. But if you find that standard care is not effective, then that's when I think the role of medicinal cannabis is important, and we should be thinking about sort of the, considering medicinal cannabis for those individuals for whom standard care is not effective. So now I want to really differentiate between sort of two major goals when people with cannabis use disorder may be attending for treatment to a medical cannabis clinic or doctor. There will be patients who turn up saying, look, I want to stop all cannabis. I'm over it. I've been doing this now for 20 years. I don't like it anymore. It's just become routine. It's getting in my way. I've probably got an RDT charge. My partner isn't happy. I'm having to hide the bong from the 5-year-old kids. They're getting old enough now. So we're seeing a lot of people in their 30s, 40s who are just starting to sort of say, look, I'm over it. I want to stop. And that's where I think medicinal cannabis has got a real potential there. Now, based on the sort of work we've done before, would recommend an 8 to 24-week treatment period using medicinal cannabis to break a lot of those behavioural patterns of addiction, and then tapering the dose over the last few weeks to manage withdrawal symptoms. I would strongly suggest using oral products, an oral THC with or without CBD. And you can see there the graphs there I have on the right. You see the difference in the time frames, what happens when you have an oral dose compared to a vaporized or inhaled or smoked dose. So the dotted line is the THC, and then the less dotted line, if that makes sense, is 11-hydroxy-THC. Both of those are active. Both of those make you intoxicated. The hard line is carboxy-THC. That's the THC COOH. That is inactive metabolite. It doesn't do nothing. So it doesn't produce effects. So what we see then with inhaled THC, or vaporized, it really only has strong effects for about 90 minutes to 2 hours. Whereas oral doses, you're seeing effects there for closer 6 to 8 hours is fairly common sort of time frame for the effects of oral. Now, whenever you're treating any form of addiction, with substitute medication, we tend to prefer longer acting or slow release medication. So think about, we don't use Xanax or temazepam to treat benzodependence. We use diazepam because it's long acting. We use methadone and buprenorphine to treat heroin dependence, not short-acting endone, for example, oxycodone, for example, because of the long duration of actions. It just allows people to function without the ups and downs over the course of the day. And again, strongly recommend counselling in addition to the medications. But what about those individuals who turn up saying, look, I'm having problems with my cannabis use, but I don't necessarily want to stop. I sort of want to get it under control. And this is really more sort of the opiate dependence treatment model, or sort of harm reduction approach, where abstinence may or may not be the primary goal of the individual. And again, I think there's a role for medicinal cannabis to assist this. You can use herb products, which tends to be more sort of what a lot of patients want to do, is substitute their illicit cannabis with licit or prescribed cannabis, and or oral products. Often I end up using a combination of products for patients, and often we'll use something like a daytime product during the day where there's less intoxication, sort of you don't have to take your cannabis with you to work, you don't have to go and sort of, have a dose at lunchtime and at every coffee break, which cause problems at work and things like that. So oral products during the day, and then if patients want sort of more of their sort of a dose to help them sort of at the end of the day with sleep and things like that, then that's where a nighttime sort of herb product. But I also know other doctors who describe, they like an oral dose at night because it can help with prolonged sleep. It is not unusual when patients initiate treatment for them to be using 2 or 3 grams of cannabis a day. And I would often look to sort of match that. I would sort of feel comfortable in prescribing sort of up to about 2 grams a day. Beyond that, it's probably not much pharmacological benefit. THC is a partial agonist, which means beyond a certain dose, you don't get much more effect. And indeed, in talking to people that use cannabis regularly, most of them will admit they get really stoned off the first 3 bongs in a session, but they don't really get much sort of more stoned when they've had their 4th or 5th or 6th bong. It just really is habit for a lot of them. So there is a ceiling effect with THC, and generally, do you need doses more than around 2 grams a day? Probably not. And then the idea is gradually reducing that over time, and wherever possible, transitioning from from herb vaporized products to oral products over time. Now, this causes a lot of people to say, well, hang on, this isn't medicine. Aren't you just being a legal drug dealer? You're just prescribing drugs to people. So any of us that's worked in the addiction medicine space for more than sort of the last 20 years, all this is so reminiscent of the debates that used to happen when we were prescribing methadone to treat heroin dependence in the 80s and 90s. It's not real treatment. You're just swapping one drug for another. You know, these patients, they're not really in recovery. They're not really getting better because they're still on a drug. In the opiate dependence space, I think most people have realized that that's not very helpful thinking, and is ideological rather than practical. That practically, more people's lives have been saved with opiate dependence treatment than any other treatment approach for opiate dependence. So, I think we should be able to get beyond that ideological issue of, if substitution treatment is somehow not real treatment. But we still need to be able to demonstrate harm reduction benefits. Now, I think there's 5 potential reasons, potential harm reduction benefits of prescribing cannabis, medicinal cannabis for patients with cannabis use disorder on a long-term basis. The first is safer cannabis products and known cannabinoid composition than illicit sources. I'm just going to jump a slide now. We don't really know what's in Australian cannabis particularly well. We haven't done recent studies analysing illicit cannabis. The best data we have is now over 10 years old, and it's from New South Wales seizures. It's actually 20-year-old data, this now, because those seizures were 20 years old, actually. And what we found way back then was almost no CBD and about 15% THC in cannabis seizures from New South Wales. The graph there on the right, we measured CBD in a group of patients presenting for treatment. We found no CBD, none, in any of the 50 regular cannabis users. These were patients using on average 2 to 3 grams of cannabis a day. And when we tested, there was no CBD in their plasma, which tells us that most Australian illicit cannabis, and that tends to be the hydroponically grown stuff, probably has no CBD and is high potency THC. Why is that important? Well, we think CBD dampens some of the potential sort of toxic effects of THC. We think that CBD may dampen some of the anxiety, some of the psychoticism. It may also be protective against some of the neurocognitive harms. So we generally think that a THC CBD balanced preparation is probably going to be safer than a THC only. The other thing with illicit cannabis is you don't know what's in it. You don't know what's in it from batch to batch. And definitely there are examples of, from the US mainly, where, seizures of illicit cannabis, and they find things that you don't want in anything that you're consuming. Illegal growth hormones, illegal pesticides, fungicides. You don't want anyone consuming these things. So illicit cannabis is essentially a completely unregulated market where people don't know what they're getting, and there's the risk of harms associated with their use. Just hurry up here. Other reasons, potential harm reduction, safer route of administration. So most clients transition from bongs and joints to much safer routes, vaporizer and oral. So vaping cannabis is much safer, we believe, than smoking it in bongs. What we often see is that client goals shift over time. So often what I would find that patients would come in saying, look, I just really want to swap illicit for legal cannabis. What I find over time is that, when working with these clients, that often many of them identify, yeah, you know what, maybe I don't need to use as much. And often that's a cost issue. Patients will realize, well, actually, 2 grams works as well as 3 grams, and often 1 gram works as well as 2 grams after a while. So often can get patients to start gradually reducing their amounts over time. A big factor for a lot of patients, it overcomes most of the legality issues of prohibition. I say most because we still have issues in Australia around driving on prescription cannabis. and also our occupational health and safety workplace regulations and legislation still has not really been addressed to deal with the issue of medicinal cannabis. The other thing is, when we engage with people around one health issue in the healthcare system, it opens the door for us to be able to address other issues as well. Now, this is important because if a large proportion of people presenting for medicinal cannabis treatment tend to be, especially with cannabis use disorder, they tend to be younger, in 20s or 30s, and they tend to be male. Young men usually don't go to GPs or to doctors. So this is also a way of engaging that population who otherwise we rarely see in sort of medical healthcare settings. And that opens the door for us to be able to address other issues such as mental health, tobacco, sexual health issues, a whole range of things that young men should be attending to, but often don't. Okay. Largely, I've been talking about THC, but I just want to mention CBD. So CBD is not intoxicating. There's no dependence. There's no withdrawal. It doesn't test positive for THC in roadside drug testing or in a urine drug test. There's interest in using CBD because not everyone actually wants to be on a THC product. They actually want to stop their cannabis use without actually necessarily using THC. Now, there's a long literature here going back over about 10, 15 years of not high quality research suggesting that CBD may have a role. The first proper study was the UK RCT done, published in 2021. This was a really nice study, 4-week trial comparing placebo, 200 milligrams, 400 milligrams, and 800 milligrams of CBD. What they found was that the 200 milligram dose did not work, and that the 400 milligram was as good as the 800 milligram, and both of them were better than placebo in reducing illicit cannabis use. So that gave us a good signal. It suggested that CBD may be better than placebo, and it gave us a dose to work with. Now, 400 milligrams is actually quite a big dose of CBD. If you were paying for it through prescription cannabis in the Australian market, that's about $30, $40 a day. Not cheap. We've also had a study come out from France in recent years looking at inhaled CBD. They've got a lot of over-the-counter inhaled CBD, and they also had some modest outcomes. The nice thing about inhaled CBD, you can get away with using lower doses because you don't have this problem of oral absorption. So lower doses equals less expensive, which there may be some benefits there. So the jury's still out about CBD for treating cannabis use disorder. Hopefully we're about to answer that question because we've just started, literally gone live in the last week, an NHMRC-funded randomised controlled trial. So here's a plug. It's just gone live in sites in Sydney, Newcastle, and Melbourne will be going live probably May of this year, the next couple of weeks. So this is a straightforward randomised controlled trial, placebo-controlled, counselling both arms, and we're looking at 250 participants from New South Wales and Victoria to take part. Okay, I'll finish up very quickly because I want some minutes for questions around what I call secondary cannabis use disorder. Think about it. You saw that data that most medical cannabis patients are using a THC-based medicine on an almost daily basis. And most of the conditions are long-term conditions, chronic pain, sleep, and so forth. So this opens the door, the high possibility that we would see secondary or iatrogenic cannabis use disorders in patients being prescribed medicinal cannabis. A recent systematic review is just about to come out, and they estimated from studies from around the world, around 20% of patients meet criteria for a cannabis use disorder, of which 60 to 80% are mild, 20 to 40% are moderate to severe. The biggest study and the best study is the study that we did using the CAMS data. All the other studies were really small. This was the only study that had a lot of participants. a third met criteria for cannabis use disorder, and 13% for moderate or severe cannabis use disorder. The most common criteria were tolerance and withdrawal, and you can see why it's important, the debate, should we even consider those for prescription medical cannabis? And it was more likely to have a cannabis use disorder if you used more THC, used it more often, if you had inhaled rather than oral, and if mental health rather than pain or sleep, and if you were younger rather than being older. So that gives us a sense of who's most at risk of a cannabis use disorder. Amongst cannabis withdrawal syndrome, a third of patients reported cannabis withdrawal when they tried to cut back on their medical cannabis. So quite high rates. I think we have a responsibility to try to avoid the mistakes of opioids and benzos that we made over the last 50 years. And I'm proposing that we should be thinking about a universal precaution framework that got developed for opioid prescribing. And this includes informed consent with patients. That's really important. Screening patients to identify those most at risk. Adjusting how you deliver treatment according to that risk. And also being aware of the importance of preventing or managing cannabis withdrawal. So we should never just suddenly stop a patient's THC medication. It should always be tapered off. Also remember, THC is a Schedule 8 medication, so you do need a permit with your local health department if you're prescribing medicinal cannabis to a cannabis-dependent person. And it's just, if you're going to stop medicinal cannabis, it should be a gradual taper, not a sudden discontinuation. All right. So in summary, we've got emerging evidence that medicinal cannabis has a role in managing cannabis use disorder, both in abstinence and as a harm reduction strategy. Much of that is for THC-based medicines, and we're yet to find out the role of CBD, but it's promising. I would always, emphasize the role of psychosocial interventions as well as medications, and the importance of being aware that some of the patients we are prescribing medicinal cannabis to for other conditions are likely to develop a cannabis use disorder from our medications. So there's my email address if people want to contact me, and I'll stop sharing. So over to you, Jake.
Thanks, Nick. That was absolutely fascinating. You captured so much. And the bad news is we don't have that much time for questions. The good news is that you anticipated a huge number of questions that I think people had. Certainly, I was forming a bunch of queries in my head, and you answered almost all of them in that packed presentation, which, by the way, I would note, I think this might even reward repeat viewing. And if you are here today, you'll get a link to be able to rewatch. And you can also find a link on our website. Just one question maybe that we can quickly go over, and that's about sort of the still emerging, not fully robust clinical data about the use of medical cannabis as a treatment. And so two things. One, what are sort of the main safety considerations that you think of? And two, what sort of evidence you really would like to see in terms of validating the use of medical cannabis for CUD?
So I think we always need to understand the difference between efficacy and effectiveness. Randomized trials tell you about efficacy. So in perfect conditions, standardized conditions with usually really good, well-trained health professionals where you screen out people with contraindications. So that's what efficacy is. And we can do more and more randomized trials to demonstrate efficacy. But real-world evaluation and outcomes is where we talk about effectiveness. So what's actually happening in the real world, not necessarily in your randomized trials. We do need much better data to understand effectiveness. There is emerging in Australia sort of two streams of how patients can go and get their medical cannabis. One is go and see your GP, who hopefully understands the role of or your specialist, for that matter, your chronic pain specialist, who incorporates medical cannabis into their treatment of your pain or sleep or anxiety, whatever it is. And then we've got the other stream of standalone medicinal cannabis clinics that, whilst there's a lot of diversity, there's concern that a lot of them really are literally not treating your condition, rather prescribing medical cannabis. So, I've got chronic pain. All right, well, here's your medical cannabis. No incorporation of all the other things that we need to treat chronic pain effectively. Psychosocial, exercise, physical therapies, other medications, and so forth. So there are concerns of what we're seeing is two streams of medical cannabis treatment. My concern is I actually think that there is a legitimate role for harm reduction with medicinal cannabis when you attend to those 5 things I was describing. Working with clients for their goals over time, shifting goals, prescribing safer products, oral, right? But these are conversations, changing the dose over time, reducing doses. These are conversations that happen once you establish therapeutic rapport, relationship, trust, and patients over time start to modify those goals. I think that's legitimate medicine. If the alternative, though, is, you hop on the phone, you do a telehealth consult with 5 minutes with a doctor you're never going to ever see or talk to ever again, and that issues you a prescription, in a 10-minute consult, and that's all you're getting every 3 months, I'm not sure what the benefits of that are, other than that is essentially providing a regulated drug supply as a form of anti-prohibition. And we can entertain arguments that is legitimate as well. The argument would be, do you really need doctors and pharmacists as intermediaries there? Or could we not have a regulated cannabis system without having to have doctors and pharmacists sort of in between the patient and supply? You can see where I'm mapping out here is actually different areas of interest. So there is a role of medicinal cannabis for people that actually want to change their relationship with their cannabis use and improve health. And then there's a role for for prescription or regulated cannabis supply for people that basically just want to keep using cannabis. Because Australia has no regulated cannabis system in place, this is really sort of the closest parallel we have in Australia to a regulated cannabis supply. And people are legitimately asking the question, is that the role of medicinal cannabis? And the debate there, is a debate I think we need to have of what would a regulated cannabis market look like alongside a medicinal cannabis market? Because decriminalisation achieves many things, but it does not address the issues of you don't know what's in your cannabis. All the profits go to criminal gangs, and that most people still need to engage in illegal activities of buying cannabis because no one's going to, very few people grow enough in their backyard. So, decriminalisation more or less perpetuates people having to do crime by purchasing drugs, which is still illegal in a decrim model. You're leaving quality control and all revenue, you're giving that to criminal gangs. So, I think the debate around what a regulated cannabis market in Australia should look like is a debate we need to be having. And we can learn a lot from how Australia has rolled out medicinal cannabis.
Right. Yes, thanks so much. That's a great reminder that this is this emerging clinical model is embedded within this much larger debate, overlapping with a broader question of how to treat cannabis, vis-a-vis the law throughout Australia. And I know that that we are certainly engaged in that. And you mentioned, the sort of how the medicinal cannabis regime is evolving. There's also the question of the rest of the world, right? And the lessons we can learn from the rest of the world, which is my segue to mention Penington's broader program of work on cannabis in general, including a series of, I think, quite compelling webinars on cannabis policy around the world. And you can find all of those at our website. But before you go running off to the website where you can find all our cannabis work, as well as a link, eventually, maybe not right immediately, but a link to today's recording, and a link to Nick's slides as well, I think we will put up there. A couple of people have asked about in questions. So before you go to the website, I'd just like to say thanks again. Thanks everyone for joining us. And above all, thanks to Nick for taking the time to share your observations, answer some of the questions that came up, and even above all that, thanks for your really path-breaking work on cannabis and substance use in general. And for clinicians and people working on the front lines, I would try and remind clients or people you come into contact with about the study that Nick is now running. So that's it. Thanks so much once again, and everybody have a great day.
Thank you all.